healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinx Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Hi, everyone, and welcome back. I'm so glad you're able to join us today because we've got a great conversation lined up. Today's session is called The Human Edge in an Automated Revenue Cycle. And it's a timely topic as well as we continue to navigate the balance between automation and human expertise. You know, we've talked about a lot of this in past podcasts and past webinars and past sessions. So this will be a continuation of that. Obviously, we're going to figure out how technology can support us without replacing us and what those insights look like, and that can still make a big difference. It's kind of that orchestration that you've probably heard us talk about in the past as well. I have a very special guest with us today. I'm very excited to welcome Evan Martin. Evan is the Vice President of Revenue Cycle Management at ZoomCare, and he's also the host of the Wilshire IT RevCast podcast, of which I was a guest about a month ago with Evan. So Evans is returning the favor, so to speak as our guest today. So through his leadership at ZoomCare and also the conversations he's had on his podcast, you know, Evan will have a very unique perspective on how automation, data, and human intelligence intersects in healthcare operations. He's had a lot of conversations about this as well. So Evan, thanks for being here. How are you doing?
I'm doing great. Thanks for having me, Stuart. I'm excited. Just for the listeners too, if you go and look me up, I've only been with ZoomCare this week, 7 weeks. So prior to that, I've done a ton of consulting and worked in the revenue cycle space since I was actually a kid. I started off as a data clerk and a dishwasher at a nursing home. So,
Wow. Nice.
So I go way back in kind of the RCM space and seeing it grow in a couple different areas of healthcare. So yeah.
Awesome. Yeah, I just knew that when we were talking about this, that you were the perfect person for this. And plus, you know, since I was on your podcast, which you can catch, we kind of repurposed that for our podcast as well, you know, kind of made it a shorter version, but you know, please go out to his podcast. He's got some great topics and conversations going on out there. But today's conversation, we're going to unpack where automation is really delivering value in the revenue cycle. Sometimes just because you need automation or you want automation doesn't mean you need automation, right? So it has its place, and where it still needs support, there's a lot of strategic thinking that goes into it. And how does the experienced RCM professional fit into all this? You know, the human specialist, if you will. So we'll talk about the persistent issues of denials. It's always denials at the top of the list, the data that most organizations still aren't leveraging, and how to build a smarter RCM strategy that blends technology with human oversight. So the conversation really isn't necessarily about AI being the centerpiece. It's about how can we maximize and optimize our RCM. So with that, Evan, we'll jump right in. So from your experience, not only at ZoomCare, but you know, all your years of experience, plus all the conversations and insights that you have from the Wilshire IT RevCast podcast, how do you see automation enhancing revenue cycle processes? And where does the human expertise remain crucial?
You know, I think we have a lot of opportunity, especially in both the revenue cycle system perspective, but even if you're just a hospital or a provider level clinic, to really focus in and start honing in kind of those top areas that we've seen automation already kicking off around, like generic coding and using AI for that. I think we're underutilizing it in our denials prevention and management product area. I think it's starting to surface there, but we have a lot of opportunity there. Then where I really think that we've always used some form of technology, but we're not using really automation to help drive it, is really around that customer service and patient collection experience platform and area. I mean, we've used, auto dialers, things of that nature to help out, but we're not going in and we're leveraging propensity to pay scores, but we're not really going in and driving, here's how we're going to automate conversations and really using like an AI agent to have that interactive conversation versus just the auto dialer portion. I think that's what will actually help save us, because more and more where we're going to need to see kind of that be our frontline defense, especially as we're all experiencing short staffing still. Since coming out of the pandemic, we've not seen our staffing numbers with qualified candidates really improve across the industry yet. We're still having to really train people from the ground up again, which is disheartening, but at the same time, it is realizing that, we as revenue cycle leaders have to start to take a different approach around what are we going to leverage and who are we going to leverage and how. Revenue cycle leaders really need to think about, as we put automation into these different buckets, how do we take our current staff and really become the RCM experts, and they're helping inform and design the automation that's coming, and then they become those check process balancers versus hiring somebody to do the registration. I mean, I know here at ZoomCare, we have most of our patients self-schedule, they self-populate their information, and then we're validating it while the automation is going out and just auto-running eligibility before they even present in our clinics. So from that perspective for us, it's really training frontline staff to be that checker to see what was missed in the automation workflow and what was missed in the patient experience workflow to do that prevention. And I think that's where we're having to retrain people to say, you're not going to be a standard biller anymore. You're going to start to audit what is auto processing for you, and then filling those gaps and those voids, but then taking what were those gaps and voids and reporting them back out so that we can make an enhancement and an improvement towards that technology base. So that's really where I see kind of that initial, where humans will always remain crucial is we're always going to have downtimes. I've experienced 2 in 2 weeks now. We're also going to always experience cyber attacks. Like, those are becoming more and more. I mean, the number of cyber attacks nobody sees or hears about, we only hear the big grand ones, right, that have occurred in the last year, but there are attacks every day that are happening, and platforms are coming on and off the systems. And if your teams don't know how to actually pivot back to fill that automation void or that technology void, we've done that, our organizations a disjustice, because we'll be behind the times, especially if you're down for several weeks at a time of not being able to leverage your technology that's in place. So making sure that you have your staff really running through what I would call not even downtime, just as you're preparing for emergency preparedness for earthquakes and tornadoes and everything, you need to have your rev cycle team running through emergency preparedness on a monthly or quarterly basis based off of their elements of technology going down, and actually work with your IT teams on shutting down that technology to test it. Because if you're not really testing it, you won't actually know if your team could respond if you're down for a longer period of time than a half hour test portion. So that's kind of where I see the human aspect still remaining crucial, is we're going to run into that. Or, we do have I live on a fault line here in Portland, and if it goes down, they're talking bridges are going to be down, and we only have one or two bridges that are actually designed for a major earthquake. Everything else is being retroed. So technology and communications is going to drop down to walkie-talkies again, potentially. So how are we going to manage communication, right? And that's going to be, if teams don't know how to process things on paper in the meantime, we'll be back to, okay, well, there went free care, and now what do we do about recovery for it? So
Right. So yeah, you always had to have that contingency plan. You bring up a very good point, how, I don't think we've talked about that enough, but when systems do go down, what do you do? And then the worst of the worst, what happens in a catastrophe? So yeah, you got to have those fire drills, right? You got to walk through the processes and make sure that you can still operate and run. Everyone's still kind of in the wave of Change Healthcare and how that affected everyone. And I know that, especially here at Infinix, our team quickly went to paper, took our clients to paper. There was not that there was a purposeful plan in place, but they were able to go, okay, this is what we got to do, and they implemented it really quickly, so no one could kind of mitigate, the damage. And that's what it's all about. So I think humans still have to have that oversight. I like, when I was on your podcast, I kind of talked about digital delegation. So you're delegating things digitally to, say, an agent or maybe automation or RPAs, whatever, but still delegation means also comes oversight. You don't just set it and forget it or walk away and go, okay, I've delegated. It's not you still have to monitor. You still have to make sure that they're in line. Yeah, to your point, that's very important.
It's no different in my mind of even looking at it from the perspective, right? Of like, if I've outsourced my low dollar collections, that's an extension of my organization. So therefore, I have somebody who's assigned to be that oversight. You have to have somebody assigned to that technology oversight on a constant team. And it really can't just be your IS component. I think as rev cycle leaders, we're like, oh, we've outsourced it. It's an agent. IS is going to manage it. No, it's your operations. You need to manage it, because when it has a hiccup, your IS team's still coming back to you to say, you're the expert. What went wrong? What do we need to fix? So having that digital delegation and oversight is going to be extremely important going forward as we become more of a technology, even more so automation based organizations.
Right, right, right. And so and just want to shift gears to like the denials,
Yeah.
they often stem from those upstream issues. I mean, earlier on in the rev cycle, like eligibility and authorization. Easy to pick on because if you don't get the eligibility, you're not getting paid, right? If you don't get authorization, you're not getting paid. But what strategies have you found effective addressing those root causes? And those are
Yeah.
examples. There may be some other root causes to improve those downstream outcomes.
So spinning off of the technology, before we even jump into technology, I think that where revenue cycle, where I would say provider-based clinics and smaller organizations have really excelled in comparison to larger organizations is RCM has a full stake or is the leader over managed care contracting. And so here at ZoomCare, I'm over our managed care contracting team. So I have a stake for my rev cycle team at the table every single day when we're negotiating contracts to say, hey, here's our denials trends, here's our overturn rates, here's what we need to put in language in our contracts. That's always your first line of defense of preventing a denial from maintaining, is getting some form of language in around supporting authorizations, eligibility, even going beyond that and saying just, if a new policy comes out, that policy doesn't just embark right into your contract day one. So contracts is always the first line of defense. The second is we need to do a better job in leveraging technology to help us analyze our denials and then determine, is it a human element or was it a policy element? I don't think we do a great job in that to say, oh, this is a policy, but did we educate our providers and our clinicians around how to prevent this denial from going forward? A lot of times it's a word or a phrase that this plan is looking for. So if we go back to a thesaurus, which I am horrible speller, I'm a horrible even looking at a thesaurus, right? But like if I go back to what does this term mean? And then, oh, yep, that's the same word for Blue Cross or for United, but they're using this and it has the exact same meaning, but the word is different. How do we leverage technology now to say, oh, doctor wrote this, but said this, but bot is looking to sit back towards, or that AI agent looks back towards what that policy word is. Yeah, it has the exact same meaning. Flip what the provider said to this word in their note before they sign off on their note, for then it to go out with that wording so that when we get the denial or request for additional information, we basically cited their policy using their own words
Right.
versus having to train all of these providers to say, okay, I have this United patient, I need to know to say it this way. I have this Blue Cross patient, I need to know to say it this way. That's not what they're intended for. That's not really what we're intended for in rev cycle. But I think that's where we can actually leverage technology to help us prevent some denials, or even leverage that to educate our providers and get their
Right.
approval to say, if it's in that thesaurus and has the same meaning, we're going to flip the verbiage in your note before you sign off. And then I really think it comes back to our business partners too, and where I think as my strategy around RCM always is using an integrated platform. So if I'm using an eligibility checker up front, I want to make sure I'm able to leverage that same eligibility checker at the time of processing my claim. And before my claim goes out, I'm going to rerun eligibility to make sure there was no hiccup, no modification. Is my address, my remittance address going to be the appropriate location to go? If I'm not doing that, I've already opened the door then for denial. And what I have seen, going back to, 3 months ago, consulting world is a lot of systems, including systems that I was over, we had one eligibility check on the front end and one on the back end, and they weren't speaking to each other. So you didn't see the variance. And what if you go with one platform with that variance, you're able to go in and say, well, why did you give me this result and now I'm getting this result? What actually exchanged your data, or was it a human element that caused that break in that platform? So I think to be able to really root cause some of that denial for that prevention, we probably need to start looking at, instead of having the best on the front and the best on the back, but what's the best for both that we both can leverage, and have more of our front end and back end teams speaking and selecting products together versus separate.
Right. Excellent. Yeah. I never, yeah, there's a lot of ingenious insights. That's thinking outside the box, pardon the cliche, but it's definitely, part of the equation, because I'm always saying, that, when the encounter, when you're talking to insurance companies, you have to speak their language. And typically that's in the realm of coding, because they look at the codes and that's how they interpret what happened at the encounter. But you're bringing a whole nother insight where you use their policies. And most physicians, when they document, they're documenting for another clinician. They're under, that's their mindset. And so when they write something down, they know that whoever is going to read this is going to understand what they're saying. But that's not necessarily the case when you're talking about payers, or even if you're talking about the judge, right? If you're going to be under compliance issues or under scrutiny. So you have to make sure, that's genius that you use their policy, use their words to go in there and write that. So I like that. I like that aspect a lot. So with the abundance of data that's available in RCM, because data is king. I always say whoever owns the most data can rule the roost, so to speak.
Yeah.
What are some common blind spots organizations face? It's almost like the forest for the trees,
Yeah.
How can they transform this data into actionable intelligence? So it's like they got all these analytics, they got all these charts, they got these spreadsheets, how can it be leveraged?
I think the common blind spots that we still see are missing charges. Absolutely. Like, providers document something, but it never gets picked up to drop that additional add-on charge, including like end taps. Like, we don't do a great job of educating our coders every year of, here's the new end taps and look for this word or this phrase, or even developing smart phrases for our provider to say, hey, I utilize this, and that smart phrase triggers a knowledge of that additional payment add-on we could be getting for Medicare for the solutions. I think underpayments as well. We have robust components of saying, hey, we have this denial and we have this, and by the time, but our denial doesn't trigger in a lot of our systems to say, wait, you got this denial, but your contract actual language and terms, like we have our rates in our system, so we know what's our expected values, but it's not saying, is this bumping up against your contract portion? So while we have all of this data, both in our contract solutions and we have rate sheets a lot of times in our EMRs, the denial is not bumping to say, do we have some form of a language that prevents the payer from actually denying this? So we write it off, and then if you're lucky and you can have an underpayment review team on your own in staff, or if you're even outsourcing to, one of the big three that are out there looking for those underpayments for you, I think that there's opportunity there that to leverage some technology to bring that abundance of data together to say, data point. I still think where we actually have a huge opportunity as an industry is around outpatient clinical documentation integrity. We see huge, robust programs leveraging that same data set for inpatient clinical document CDI, but we're not seeing it as fully leveraged at major health systems on the outpatient platform, and looking at provider clinics and looking at certain specialties. So I'm even looking at that right now, is how do we start in my women's health and in my more emergency room type platforms here at ZoomCare to say, okay, let's focus in on there where we have a higher dollar, a higher risk of something missing, or being able to educate our providers from all that data we have, but we're not leveraging it to go back and educate. Then I think, the biggest, Stuart, the one thing that when thinking about this question early on, when we were prepping, I don't think revenue cycle gets the patient satisfaction data. And I don't think organizations do a great job. We do a great job in collecting the clinical portion, but let's face reality. The first person to see the patient is revenue cycle. The last person to interact with the patient is revenue cycle unless there's like
Right.
some form of complaint and compliance and your patient advocacy teams getting involved. But if everything's going great, we should have better data. And where we lack data is getting that data around patient satisfaction, around how was registering and how was their interaction about pre-collections and knowing what their out-of-pocket estimate would be. And then how was their experience paying their invoice and or getting their invoice explained to them, or if they happened to end up going to bad debt and didn't know that they could have had a payment plan, how do we educate them and bring that back in-house? So yeah, we pay the fee to bring it back, but it's about satisfying that patient's experience in the long run. I mean,
Mhm.
we can make or break it for our organization whether or not somebody comes back. And I think that's forgotten sometimes. So I think taking more of a robust data approach about asking those types of questions to our patients is going to be critical and key. And some organizations, I know like the University UCLA, their PB team usually does an every other year annual survey back to their patients through one of the survey platforms. But I think that it should be embedded in everybody's culture as part of just their routine survey process.
Right, right, right. And then act on that feedback, use it
Yeah.
to learn and improve. Absolutely. So in your discussions on your podcast, Wilshire IT RevCast, have you encountered any misconceptions about AI and RCM, and how can organizations set realistic expectations when
Yeah.
integrating those technologies?
I think AI term is just, it's funny that we say this. And I remember talking to you about this on the podcast.
Yeah.
AI is this black box, right? Like it is Pandora's box of everybody's like, oh, we have AI. Oh, we have this. I think as leaders, we have to step back and ask every business partner, okay, put the buzzword of AI aside and really what elements of technology are you using? Are you
Mhm.
using RPA? Are you just screen scraping and then you're spitting out something to me? Do you have an AI agent that's interactive with the front end of your revenue cycle and your back end, and AI
Mhm.
agents being interactive with each other? Do you, I had somebody say, oh, we have AI, and it comes to find out it's an auto dialer. Well, yes, they're leveraging elements of AI to make that auto dialer work, but it's not then that agent who's having the conversation. I still have to staff somebody on the other end after the patient pushes one, right? So
Right, right.
there's elements of that where I think the buzzwords around it is what causes the misconception. And I also think, they're out of the game now, so I can use their name. The whole olive debacle really put a distaste in in us from revenue cycle leaders, because we were trying to be early adopters. We were trying to get into that game. And then all of a sudden they step out and you don't know who's picking you up, or you don't even have the staffing infrastructure because you outsourced it to some form of technology to run for you. So I think that's where it goes back to us. There's always a human component and you always have to have a downtime plan, right? That
Right.
and be running that. But at the same time, we really need to ask more questions as leaders, and we need to take the ownership of it versus putting it on our IS teams to ask those and say, okay, well, what does this really look like? And I think that's what causes the misconception, is because there's no true definition of what artificial intelligence is in RCM space. It's a
Right.
host of solutions and tools that are out there.
Right. Right. Exactly. Couldn't agree with you more. Absolutely. Well said. And then considering the evolving landscape of RCM, how do you envision the balance between automation and human oversight changing in the next few years? I mean, I definitely have an opinion on this, but I want to I want to hear yours.
I think from my standpoint of what I'm looking at is even like looking at my minimal staffing right now. I have 50 provider clinics throughout Washington and Oregon, and I have 4 coders on my team. I have to bring an AI agent in to help with coding, right? Like I'm watching this backlog on being on a new EMR platform, and we're just not able to physically touch everything. So
Mhm.
my goal, and where I think a lot of leaders' goals are going, talking with peers, is probably to have like a 50-50 mix for the next 2 to 3 years. Within the next 4 to 5 years, I would say we're probably going to be a 60-40. 60% of our workforce is going to be some form of automated platform, and 40% being the auditors, the checkers in case of an emergency downtime. And I
Mhm.
think that also goes back to where are we at in the industry? We are watching, the largest population we're caring for still today is the baby boomers, which, it's funny, I was talking to my mom about this yesterday. Most of her friends, as being a baby boomer, my mom is very technologically savvy. She still works. She uses computers on her phone all the time, but she has peers who don't even have a computer at home or a smartphone. They still, they're opting not to have that yet. So where what we need to look at is really how do we leverage the right technology for the right person. And even myself, as I'm getting older, I don't want to talk to a chat. But by the time I'm ready to interact with your customer service team, I've already talked to your bot. I haven't gotten the answer I want, and
Right.
I still have questions outstanding. So I need that human touch. So I think we'll never get rid of the human aspect of it. We'll always have some form of percentage, but I think it'll probably be more of that 60-40. What are you thinking? I want to know your thoughts
Yeah.
on this too.
Yeah, I'm thinking about the same kind of go where it the frustration, and it also depends on the audience. I think it's going to be a mix still until we get like to your point about the baby boomers. And I love the fact how you've already maybe spoken through to a bot or someone. I can just, see myself screaming into the phone, representative, and you're
Yeah.
trying to understand. You're already at a point where you're just frustrated, and who wants to talk to someone, like that. But I do see where kind of you made some points earlier in our conversation about this where the agents are actually taking on the conversations where they're actually, and I think that's going to increase. We've already seen it in other industries.
Hmm.
Look at the retail industry. You can look at restaurant industries, taking reservations over the phone. And it really does where it's sounding very much like a human. And it has those machine learning models. It's actually knows, and it's not just reacting to a preset determination of answers. It's actually finding out what the answer really is and then delivering that answer. Still not be satisfactory completely because you're still going to have the human element where they need to take care of someone. But I really see it evolving, at least in that area where, and even talking to payers. I mean, can you imagine an agent that's arguing on your behalf to a payer?
Yeah.
And that would I see it kind of going that direction. And it won't, I don't think it's going to be very long because I know even our product team, our chief product officer, Navneet Nair, he's even made comments as like 6 months ago, he didn't think any of this was possible. And here we are 6 months later, and it's like, wow, it's amazing what the technology is doing.
Yeah, I was just looking at a potential startup, just talking with them about it. They were asking me about some RCM stuff, and they threw me on with an agent, and I simply said, "Hey, how's your day going?" And took it a second, and then all of a sudden, I was like, "Oh, my day's great. I'm doing this later today." And I thought, like, if I didn't know that they were putting me on that beta site to just like listen and ask it questions, I totally would have just thought, oh, there was like a communication delay on the phone for them to be able to respond back to me, and it was
Mhm.
just kind of them coming off a mute being in a call center. They even had a call, like it sounded like it was in a call center with like some people chatting
Wow,
in the
that's awesome.
background.
Yeah,
So
make it
I,
sound
I
real
really
authentic.
do think we are going to get there quickly, and it's also kind of scary at the same time if you think
It
about
really
it,
is.
especially with how much cyber like individual security and attacks are happening like with your own personal information right at the same time. But we're going to have to get there to be able to maintain, because people aren't wanting to come work in healthcare. I don't know why, but you always have a job for the most part. But
Yeah, it's
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 becoming hard
recession
to
proof.
recruit. Yeah. So
It's recession proof. Well, I know that's all the questions I have. I do want to turn this over to the audience. Let's see, we have one question here, Evan. And for organizations that are just beginning to implement automation in their RCM processes, what initial steps would you recommend to ensure a smooth transition? That's a very common question.
yeah, that is very. I first, don't go in thinking that you're going to have a smooth transition, because you're not. Whether you're working with a platform that has done 100 implementations or you're their first, it's always going to feel like you're your first, because let's face it, while we all say we're unique, we really are in our own workflows and processes and learning what we need for platforms and what our expectations are. What I would say is set your expectations at a medium percentage. Go in with agreed upon KPIs and risk models when you're bringing that in, and ask for a proof of concept out of the gate. I think putting the technology in place first under a proof of concept where you're not paying for it until after it's implemented and you've seen the proven worth of it within a 6-month period of time, then will help us as individuals say, okay, now I'll pay that implementation fee. Now I'll pay for that. I think our business partners out there who are willing to do that are the ones that are on the cutting edge, because they want to prove their model to you, because then you become that spokesperson for them about their success. So if somebody's like, nope, we're just going to slap it in, here we go, I would be a little more leery about it in that regards. And do your shopping. Like, I think for the smooth success implementation means that you really shopped and you brought all your stakeholders at the table. I know I'm looking at some automation right now for my team, and I have my application team there, I have my IS team there. I actually have a clinician at the table too, because I want to know what the clinicians' thoughts are of what we're going to be selecting, if it's going to be something that's going to impact their work, their RVU, or what the actual outcome of it is. So I think you need to take that holistic approach and everybody say, this is what I need out of it, and then look at, okay, what does that implementation timeline look like, and then add 2 more months to it, because you want it slow and steady. Don't slam it in. So
right, absolutely. And we do have one more question.
Yeah.
We have time for one more question. Here's one from someone in the audience, and it's near and dear to my heart because I'm a certified compliance officer. So I really like this question. How do you recommend staying compliant when you automate your coding? There have been several cases brought forward by CMS where providers used this technology and found incorrect coding.
Yep. So that's where you have your coders as your auditors of the AI. So what my initial thought is, you are going to implement through proof of concept. You're going to do 100% stop of everything initially out of the gate, and have your coders go through and look at, yes, this meets what we believe meets our coding guidelines, whether that's a HEMA, whether that's AMA. I think that's where CMS is eventually going to have to say, okay, who is the owner of our guidelines? Because it's not always clear. We have some coding per AMA, some coding per HEMA, but as long as you have your policies that's written to support that, I think that ultimately you'll be fine in that regard. So look at it, turn your coders into an audit, start small in a smaller space too. So don't just go big bang. Look at it, okay, I'm going to automate orthopedics first, or I'm going to automate family practice first, or whatever that may be. And then once that's in, then move to your next one. And once that percentage hits what you and your compliance department say is a reasonable risk variable, then move to your next one. So if that is, 80% of the charts are coming through correctly, and we're going to always do a 20% review, or if it's going to be a 90-20, I think that's where you and your compliance teams are going to have to be in agreement what that risk model looks like. But ultimately, you're going to turn your coders into auditors, and that's what's going to make you successful in the long run.
Yeah, sound advice. And there are automations out there that will pull out and do some preliminary checking and pull out the encounters or the coding that's right, so they don't have to audit those, and pull out the ones that need attention. So it's very crucial to kind of have audit. You can use AI to monitor AI, but you still need a human element, to your point, to monitor that, turn into auditors. So awesome. Well, Evan, thanks for being on board. I mean,
thanks for having me.
Yeah, we'll need to have you on again for sure.
Happy to, always.
Very, very excited to have you here. And thanks for everyone for joining us.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.